Evening, everybody. At the outset, I would like to thank Dr. Kamaluddin and his entire team for the kind invitation. Over the next 25 minutes, I will be talking to you about decision-making criteria in radiation oncology. What is different about oncology as we practice it today? We have a better understanding of the biology. Multidisciplinary efforts are instituted appropriately. Better and more accurate tumor assessments are possible because of better pathology, radiodiagnosis, nuclear medicine. Superior radiation therapy techniques are utilized as and when possible. This allows better assessment and target delineation and OAR contouring. Planning, delivery, and verification are possible to a more sophisticated extent. Better surgical techniques are employed. Optimal utilization of systemic agents. Most importantly, appropriate institution of supportive care to ensure that the patients complete their planned multimodality treatments. There is an increasing awareness amongst the entire team about the inclusion of rehabilitation, attention to quality of life issues and patient-related outcomes, all with the ultimate goal of improved outcomes and better quality of life. Today, we have the patient at the center and an integrated approach from all team members to ensure that the patient completes planned treatment and we have the best possible outcomes, paying attention to quality of life and patient-related outcomes. Cancer decision making is complex, involves multidisciplinary inputs, and is ever evolving because of emerging literature, carries financial implications both for the patient, their caregivers, and the treating team. The goals of cancer treatment from a patient's perspective involve cure and control, palliation of symptoms, prevention of recurrence, and the ability to return to a normal life and return to work and their means of livelihood. From a physician perspective, it should be effective, affordable, pragmatic, with minimal or the least possible side effects, ensuring a good quality of life. The physician's responsibilities involve provision of patient-centered care, responsiveness to patients' desire to be involved in the decision-making process, understand patient preferences and values regarding treatment options, improve patient satisfaction with the decision-making process, and potentially improve patient health outcomes. The common dilemmas faced in oncology decision-making involve the choice of investigations to complete the staging workup, curative versus palliative treatment, disclosing the prognostics to the patient, especially in our part of the world, the modality of treatment, the use of multimodality treatments and the sequence of treatments in that regime, and of course ensuring adequate follow-up, a convenient and effective follow-up schedule, and the investigations that need to be carried out during follow-up. Now, while talking about treatment modalities, the factors that influence the choice of treatment consist of the patient-related factors, which include all the plethora of factors that actually are responsible for successful completion or choice of treatment. The tumor-related factors are importantly the site, the stage, and the volume of disease. And treatment factors, of course, include expertise available, the physician's philosophy, and the cost and feasibility of executing a particular treatment. Now, in certain organs and structures, it is important that we understand that mutilative surgery has now given way to more organ and function preserving protocols. And there, the endpoints of interest are important to keep in mind. Good disease control is of paramount importance and involves local control, ultimate local control, cost-specific survival, and overall survival. And of course, when we're talking of preservation of an organ, especially in the head and neck region, it talks of and involves attention to voice preservation, preservation of swallowing and respiration, reducing the chances of aspiration with an acceptable quality of life. Now, to make these choices as well as decisions more objective, literature today actually talks of various decision support systems, which are essentially information systems that support business, medical, education, or organizational decision-making activities. and essentially is a fusion of human knowledge and technology to support and improve decision making, and perhaps make the decision making more objective, but which we understand as practitioners that may be difficult, because finally at the end of the chain is the patient, or rather the center of the chain is the patient, and we have to keep the patient's considerations in mind, and not one size fits all patients. The other important thing as proposed by Gladser is this decision making process, which actually has three main domains. One is the decision maker related criteria, which means about the physician, the philosophy, the infrastructure. The decision specific criteria, which takes into account several patient related parameters, disease related parameters, and importantly the contextual factors, which are the environmental parameters essentially, which can enable rather the completion or success of a particular treatment regime. Now coming to the role of radiotherapy, almost 70 to 80% of solid tumors require radiotherapy at some point in their treatment. Gross treatments typically require doses of around 66 to 70 gray. I'm talking about squamous cancers. Microscopic disease or high-risk areas would require about 56 to 60 gray, and microscopic low-risk areas would require about 45 to 50 gray. Factors that affect the decision in patients while deciding on radiotherapy, of course, include the factors that I've already spoken about, that is age, performance status, comorbidities, disease status, financial factors, and logistics, and the available expertise. Now, this is a schematic diagram showing a conventional model of decision making. This has been described by a paper by Christina Woodhouse from MD Anderson, and this is a schematic diagram talking about what I've already spoken to you about, that is to take into account the patient factors, the doctor factors. There is an exchange of information available which actually involves both the physician, from the patient, then discuss the options available once you have reached the stage. And this would of course take into account whether this is advanced stage, early stage, what are the options available, whether it's curative treatment, palliative treatment, and then finally make a decision. What this essentially incorporates is evidence-based outcomes information, guides patients towards choosing the treatment option that best aligns with their preferences and values, provide patient-centered care, be responsive to patients' desire, understand patient preferences, improve patient satisfaction with decision-making process, and potentially improve patient health outcomes. So now if I were to elucidate or rather exemplify all these with the head and neck cancer, this is a study that has been done on therapeutic decision making in stage 3 and 4 cancers, 591 patients over an 8-year period. This is the distribution of the demographics and tumor site and stage parameters in the entire group. This is the outcome with regards to the disease specific survival and the overall survival in this group. And this is if they are divided into various groups depending upon whether the disease is unresectable, whether elective surgeries have been done, the unhealthy group, that means if they had comorbidities, and the patients who underwent surgery. Now, the conclusion is nothing to do with the disease per se, but what it tells us about the system is that if you were to analyze all consecutive series of patients with advanced head and neck cancer, by including everybody, that is patients who had comorbidities, who were non-compliant, it would be possible to actually counsel the patients on the realistic expectations after treatment. And it also dramatically shows the impact of age, comorbidity, and advanced stage on survival. The site and state specific data are useful in counseling patients with advanced head and neck cancer regarding treatment choices. Now, I'd just like to discuss a few of the parameters that have an important bearing on treatment decisions, including radiotherapy treatment decisions. One of them is comorbidity. This is our own study on 518 patients, where we found that the higher grade of comorbidity led to less likely completion of guideline concordant therapy. Also, patients who completed guideline concordant therapy had the best outcomes. This stands to logic. And if you look at this distribution of the various parameters about patients who had no comorbidity versus any grade of comorbidity, of course, it's a function of the age, it's a function of the gender, and of course, of the end stage also. Now, this is another systematic review of the impact of comorbidity on treatment outcomes in patients with head and neck cancers. Prevalence of comorbidity increased with age. It influenced treatment and treatment selection, was associated with lower socioeconomic strata. Overall survival was significantly worsened among patients with comorbidity. And increasing comorbidity score was also associated with increased risk of death. Now, this is again an analysis done on the ECOG performance status in head and neck squamous patients and the association with socio-demographic and clinical factors and overall survival. What the investigators concluded was that the evaluation of the physical consumption in head and neck squamous cancers at diagnosis may indicate a more aggressive type of malignant disease, and this would also help identify those patients that need rapid referral or who may benefit from specific therapeutic and rehabilitative interventions. Now, coming to radiation therapy in particular, again, I am talking about keeping in mind head and neck cancers because that's what I specialize in. The first and foremost decision that needs to be made is whether to give radiotherapy or no radiotherapy. That is often a function of the site of disease, the extent of disease, and of course the expertise that is available. Typically, oral cavity cancers are a common problem in India. Evidence-based guidelines tell us that in the presence of resectable oral cavity cancers, however advanced they may be, surgery is the treatment of choice. However, we do know that surgical expertise for these advanced tumors may not be available at all centers. Then do we do radiotherapy? How will we decide to do or not to do? So if surgical expertise is not available, we could do radiotherapy, of course, explaining to the patient the lower probability of cure and perhaps a higher probability of treatment-related sequelae. Now, intent, radical versus palliative. Treatment site, the disease site, extent, as well as patient-related factors like comorbidity, age, often determine whether it should be radical or palliative. Dose fractionation schedule, again are a function of the volume, location, proximity to critical structures, and the availability of infrastructure. Now the technique, conventional versus IMRT. Again, it is a function of dose fractionation and schedule, intent, radical or palliative, and in particular the volume of the gross tumor volume, the clinical target volumes that have to be encompassed, proximity to critical structures, the normal tissue complication probability versus the tumor control probability, availability of expertise and infrastructure, and whether the radiotherapy will be combined with any concurrent systemic therapies. The aim of any radiotherapy would be to try and separate these curves as much as possible, the TCP and the NTCP curves. Now, a word of radiotherapy. Now, in head and neck cancers, we have traditionally used conventional radiotherapy techniques. Thereby, if done properly, achieving acceptable controls, but knowing fully well that we are going to be delivering higher doses to critical structures with antecedent higher toxicity. Simply means that we have achieved a suboptimal therapeutic index. Now look at this complex geometry of head and neck tumors. A nasopharyngeal cancer, large target volumes, both the high dose levels as well as the low dose selective levels, the proximity to critical structures like the brainstem, the optic pathway, various other structures like the parotid glands, the swallowing apparatus. Using conventional techniques, we may be able to achieve this, may be improved further with the use of conformal therapies as well as tissue compensators. But keeping fully in mind the fact that we will be delivering higher doses through the OARs. So the role of advanced technologies in head and neck cancers essentially has the ability to enhance, improve, maintain locoregional control, theoretical possibility of dose escalation, reduction of the commonly encountered side effects, aims to reduce these sequelae, and by doing so may improve the quality of life. So what we could achieve with conformal techniques is possibly a progressive confirmation of the radiotherapy dose delivery. Another example is while choosing the radiotherapy technique, another criteria that we could possibly use is that if you're going to give a radical treatment, a structure or a tumor in the PNS close to the eyes, the globes, the optic nerves, of course, the technique of choice would be IMRT, because this would help us not only to deliver the doses that are necessary, but also limit or restrict the doses to the adjacent normal structures. Our own experience with 3D CRT versus IMRT is that we can achieve equivalent control rates between the two. There is no difference in survival. And in nasopharyngeal cancer, the study by Peng definitely in 600 plus patients definitely shows that there is a survival advantage. And of course, IMRT results in better doses to the adjacent OARs as compared to the 2D CRT group. This is also our own experience where there was a reduction in the xerostomia in patients who were treated with IMRT. Now, of course, we have to remember that all this comes with resource implications. Again, a study done at our institute, we divided the entire process into several individual steps. And what we did learn, not surprisingly, of course, is that the time required for all these processes are more labor and time intensive, which simply means that we have to have adequate infrastructure and resources to carry these out. We don't know that there have been several advances with regards to this. And this was, of course, before the use of volumetric arc therapies. And we know that with the use of that, perhaps we can definitely reduce the overall treatment time and improve the throughput on the machines without compromising target coverage or improvement in doses to the OARs. Now, decision making is especially important when we talk about recurrent cancers. This is a very commonly quoted paper from Alan Ho, which talks about improved outcomes in patients who are selected appropriately even after a recurrence. And here they actually talk about important prognostic factors which would help in the better selection of patients and adjuvant therapies in patients who've had a recurrence. Now, re-radiation especially has several issues, and these essentially pertain to patient selection, combination of treatments, target volumes to be radiated, OAR doses, the toxicities that you would anticipate or keep in mind, fractionation that has to be employed, the technique and the dose. And these are points from the appropriateness criteria which ensure that we have these information before you consider a patient for re-radiotherapy. Now, this is an interesting study carried out in the Netherlands. And the only thing that I want to show you out of this study, of course, is the fact that for all these quality indicators that they had evaluated, there were 9 which were very important with denominators of more than 400 patients. And where you can see very importantly that certain information which are important in decision making and deciding on radiotherapy, especially for in treatment for head and neck cancers, like having a multidisciplinary clinic, discuss the treatment plan, were available for practically all patients. And this was irrespective of the hospital setting. But certain other things, like whether you had somebody to explain treatment options, a nutrition plan, they differed. And what were the important factors? The site, stage, the kind of hospital volume or the treatment volume or the tumor volume that you were dealing with. Now, this is another important aspect, that is the patient's preference. This is a study conducted in 38 head and neck patients interviewed prospectively to look at what are the themes or sub-themes in the various interviews and the number of and the kind of importance. And if you look at it, of course, very important were parameters like information from healthcare provider, the likelihood of treatment success, the risks and benefits of treatment, very important, and the patient specific factors, essentially the family support and the money matters. Now, another important aspect which goes a long way in deciding about what kind of treatment can be given to a patient is the availability of infrastructure. And we know that in this part of the world, we are appallingly low in terms of infrastructure that is available and necessary. Of course, we are improving, but we are a long way from there. The other important or distinctive feature that we have in our part of the world is the cost towards treatment, and it is unfortunate. Of course, several countries have taken it up in a big way, and even in India, I must say that we now have publicly funded insurance schemes ensuring that the families have adequate coverage, but even then there's a large proportion of patients or large proportion of out-of-pocket expenditures that a patient has to undergo or undertake during treatment. And this is, of course, a distribution of costs depending upon the kind of treatment that is being undertaken. Most importantly, I like this table because it kind of shows you what happens as you combine radiotherapy with either surgery or chemotherapy or both. And you can, of course, see that there is an incremental increase in the value, the cost that is necessary for these multimodality managements. A very important treatment that has to be kept in mind is palliation, because this is a point in time where we have to think about disease extent, age, comorbidities, performance status, the logistics, and other issues. Here it is very important for us to look at the radiotherapy, chemotherapy, and the various sequences of therapy that need to be used. And very importantly, from the radiotherapy point of view, the dose, the fractionation, and schedule. Now, this is a study that has looked at survival after palliative radiotherapy for cancer. And this is a kind of model that has been developed to kind of be able to predict what is the outcome going to be like. And it takes into consideration factors like the location of the metastasis, the age, the primary tumor, the gender, the comorbidity index. Here they have used the Charlson-Deo comorbidity index, the radiotherapy site, and of course they have looked at the median survival times, and this could be possibly used to predict survivals. This is a systematic review looking at clinical decision support systems that are available for clinical oncology practice. Despite availability and despite a lot of literature being there, there is a paucity of data evaluating clinically relevant outcomes of these systems. But what is there seems to be encouraging and could go a long way in supporting the clinician in making meaningful decisions. I'd like to conclude by saying that decision making in radiation oncology is complex but essential, multidimensional, individualized process, and it is not only about radiotherapy, because the entire milieu will go a long way in being able to ensure the successful completion of meaningful radiotherapy. And of course, there are various clinical decision making systems available there, but they're still in their infancy as of now, but have a promising future. Appropriate patient selection, most important, choice of technique, combination with concurrent therapy would then follow, and of course the institution of supportive care. I'd like to end my talk by elucidating the entire thing that I've spoken to you about. This is a patient who presented 55 years of age, no comorbidities, presented with hoarseness of voice, found to have a growth in the right piriform sinus. It was moderately differentiated squamous carcinoma. So what is the first step? Of course, a good clinical history taking and clinical evaluation, followed by the appropriate imaging so that we can come at a disease stage. And then very importantly, for a hypopharyngeal cancer, we need to know the functional status of the organ. Having done all that, we now know that there is a disease that's involving the piriform sinus with extension into the oropharynx, which is quite evident here. It's a stage 4 disease because of the extent as well as because of involvement of the thyroid cartilage. So based on this, the composite stage would be a right piriform sinus T4A N2BM0. What do we need to take into consideration? The age 55, performance status 0, Comorbidity, none. Tumor extent, unresectable or extensive resection would be necessary because of extension to the oropharynx. Patient desire, not keen on extensive surgery, does not want to lose his voice and does not want to have a permanent tracheostomy. Availability of expertise for alternative treatment, yes. Is it evidence-based? Yes. Cost implication, prolonged treatment. Hence, this is something that has to be discussed with the patient and family. In view of the relatively younger age, considering all the above parameters, it was decided to treat this patient with neoadjuvant chemotherapy and assess later. Patient underwent 9 cycles of weekly paclitaxel and carboplatin. The response after chemotherapy was almost 70%. Still had some cartilage erosion, but the larynx was still functional. Hence, keeping the patient's wishes in mind, knowing the ultimate goal, we still went ahead with conservative disease management, conservative treatment protocols. And this is the response after completion of neoadjuvant chemotherapy. So the patient was treated with concurrent chemoradiotherapy using 3D CRT with beam shaping, conventional fractionation. So received 70 gray, 35 fractions over 7 weeks. At 12 weeks post completion of therapy, this is the kind of response that we saw. So it was a complete metabolic response. Patient continues to be on active follow-up, no evidence of disease, has grade 2 xerostomia with minimal hoarseness of voice and has resumed work. Thank you for a patient listening, and I'd be happy to answer questions if any. Thank you once again.